Major insurance companies in the United States have become increasingly involved in healthcare delivery, including by acquiring physician practices and care delivery companies. This type of consolidation could have implications for healthcare costs, patient care, and physician morale. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Erin Fuse Brown, a professor of health services, policy, and practice at the Brown University School of Public Health and a member of the journal's Perspective Advisory Board. Professor Fuse Brown has co-authored a perspective article about payer-led vertical consolidation in healthcare. Professor Fuse Brown, what is meant by the term vertical integration or consolidation?
Vertical consolidation in general refers to the combination of one or more different elements of a supply chain. So, for example, traditionally in healthcare, vertical consolidation referred to hospitals acquiring physician practices. But what we're talking about here is another form of vertical consolidation, where we see insurance companies or payers increasingly acquiring ownership or control stakes in both physician practices, but also pharmacies and other types of healthcare provider entities.
What's driving this trend of acquisitions of physician practices and care delivery companies by insurers?
So I think a big driver of this trend of vertical consolidation that is being driven by insurance companies is the shift that we're seeing, particularly in the Medicare program, toward more capitation-based financing. So under these financing models, the government basically says, we are going to pay managed care plans, Medicare Advantage plans, a capitated payment, a per person, per beneficiary payment, and we're going to adjust that payment based on sort of the sickness or the diagnoses of that beneficiary. So there is a way to assume the financial risk and get sort of a lump sum payment if you're an insurance company, and you can increase those payments if you then align with or acquire a controlling stake in the physicians who bring those patients along with them. They bring their patient base, they bring their patient data, and the ability to increase those capitated payments with additional diagnoses and other information from the medical record of those patients.
So, what are the potential implications, both positive and negative, of this trend for patients?
So I think one of the implications is that because the shift in particularly Medicare, but not just Medicare, but Medicaid and other types of payment is shifting from fee for service to this sort of capitated risk-based payment, we've often seen this as being part of a push towards something positive for patients, which is value-based care, paying for value or outcomes, paying for coordinated care instead of paying just on a unit of service basis. So that, of course, is one of the theories behind why we might want to see managed care taking a larger role of integrating the payment and the healthcare delivery side of the equation. So that's the positive spin on it. The negative spin that we're seeing is, of course, that these are for-profit entities, these insurance companies like UnitedHealthcare, but also Aetna, Cigna, all of the major insurers are pursuing the same strategy. And they're doing so not necessarily to better coordinate care, but they do so in order to make money for their shareholders and their investors. And so the risk to patients is that if your insurance company acquires your physician's office and also owns your pharmacy and also controls the pharmacy benefit manager, that they have an outsized say in the location, the type of care you're getting, whether or not you're going to be authorized to receive that care under a prior authorization system, and whether their financial incentives to sort of cut costs, again, increase their own payments by exaggerating perhaps your diagnoses or maximizing your diagnoses. On the one hand, that could prove beneficial to a patient, coordinate your care, have more touch points with your healthcare provider, with your pharmacy, a lot more, again, seamless transitions. But you also are part of an ecosystem now where your data and the ability to market you and steer you might be, again, in their interests more than they are in your own choice or your choice of provider or pharmacy or physician practice.
And then, what about implications for the healthcare system in general?
So one of the things that we're seeing is that the implications for the healthcare system is, even though there was sort of a cost-saving push with this shift to value-based or capitation-based payment, what we're seeing is, in fact, that there are lots of ways to still make a ton of money for these insurance companies who then acquire physician practices and other types of provider systems. And so with this increased access to all the patient data, including the data that comes from the claims processing pipeline, which is like the Change Healthcare company that United acquired. All of this comes with the opportunity to make money through a series of strategies. One is, as I mentioned before, the ability to just increase your per capita capitated payments by increasing the amount of coding that you do for each patient. But there's also ways to basically move money off of the insurance company's books and move it to the pharmacy or move it to the physician practice. And these are called intercompany transfers. So paying your own subsidiaries for healthcare services allows you to sort of hide, if you're an insurance company, hide your revenues and disguise administrative overhead as healthcare costs so that you can then basically overpay your own pharmacy, or you can overpay your own affiliated physician practices. And then what that does is it sort of makes it hard for the independent pharmacies, the independent physician practices who are not part of the ecosystem to compete. And so what we're seeing is that for the healthcare system, it not only increases costs by, for example, inflating the amount that Medicare Advantage is paid relative to traditional Medicare, but it also means that the individual markets, particularly rural markets that have a loss of competition and a loss of services, are seeing the independent pharmacies disappear, are seeing the independent practices being pushed either into the arms of these large healthcare conglomerates or have to close their doors. So I think that what we're seeing is the effects of this consolidation, particularly is being felt by the disappearance of the independent pharmacy and the independent physician practice.
In your article, you mentioned the recent ransomware attack on Change Healthcare, which is a medical claims clearinghouse owned by UnitedHealth. In what ways might vertical integration affect the risk of or the implications of this kind of attack?
So one of the things that we saw with the United Change Healthcare attack is that Change Healthcare was part of one of these companies that was very, very big, but not too many people knew about it before United acquired it and before it was attacked by a ransomware attack. But basically, it's the billing and claims processing pipeline that connects the vast majority of the healthcare system. And so when Change Healthcare was attacked with a ransomware attack, it basically moved offline millions of physician orders, millions of pharmacy prescriptions, millions of scheduled health record updates, and all the sort of routine electronic back end of the healthcare delivery system was seized by this ransomware attack. And so Change was already a big player, but once it became integrated into UnitedHealthcare, it became part of a conglomerate that frankly was too big to fail. And so United, which is the largest health insurance company in the country, it's also the largest employer of physicians, now owns the largest claims processing. It has the third largest pharmacy benefit manager and also operates mail order pharmacies. Put together, that is a healthcare system that is occupying such an outsized footprint in the United States healthcare system that if you seize it up with one targeted ransomware attack, the ransomware attackers can disrupt the functioning of an entire swath of the healthcare system. And so it's exposed a degree of vulnerability that consolidation has created. We've been long aware of the risks of consolidation on things like increasing healthcare costs or decreasing access. But what we didn't really fully comprehend is the degree to which consolidation also makes the healthcare system more vulnerable to attacks like the Change Healthcare ransomware attack.
Finally, what steps could policymakers or regulators take to address concerns about this type of consolidation?
So there are a series of tools to address this type of consolidation. The first is to name that this is a form of consolidation that is underway and of concern. I think that for a long time, vertical consolidation, particularly involving managed care or the integration of the payment and the delivery side of the healthcare system, has been given a rosy pass by regulators by saying this is going to increase efficiency, it's going to increase care coordination. But what we're seeing is it also creates a series of risks and vulnerabilities. So I think that there are several steps that the policymakers could take at the federal and at the state level. One way would be to sort of reduce the amount to which, for example, the Medicare Advantage payment system can be taken advantage of or overpaid through the strategies that are used by these sort of payer-provider consolidations. Congress could also, just in general, direct more resources and support and increase the authority of the antitrust authorities to be able to target with investigation and enforcement, if it's necessary, these types of vertical consolidations. Notably, the UnitedHealthcare's acquisition of Change Healthcare in 2022 was challenged by the Department of Justice under antitrust grounds. But the court in that case basically dismissed the case and said, we do not see a competitive problem. This is vertical consolidation. It's not old school horizontal monopolies. And so the court was unconvinced that there was a competitive risk. And of course, only now are we waking up to see the reality, which is that these vertically consolidated entities do pose competitive risks as well as systemic risks in terms of the vulnerability to attack. But the other way that we could see Congress taking a more proactive approach would kind of enforce a separation, a bright line separation between those on the payer side of the equation, the health insurers and the pharmacy benefit managers, From the other, the care delivery side of the equation, that we think that there's a systemic risk when the PBM owns the pharmacy, when the insurance company owns your physician practice or your home health provider, and that this encourages sort of a conflict of interest and an opportunity for financial gaming that really isn't good for the healthcare system, the taxpayer, or the patient. And then finally, there are steps states can take as well to strengthen traditional bans on the corporate practice of medicine that basically bars corporations and insurance companies from employing or controlling the practice of medicine and the individual clinical decision making by physicians in a way that, again, could protect physicians and their patients from corporate control if their practice is acquired or affiliated with an insurance company, to make it so that the physicians are no longer sort of beholden to the cost and the profit seeking motives, the coding implications, the contracting implications, and the care delivery implications of being controlled by the person who's frankly paying your bills.
Thank you, Professor Fuse Brown.